We will start firstly with Eric Albrecht. He's the program director of regional anesthesia at University of Lausanne in Switzerland. And he will be considering if interscalene blocks should raise concerns about neurologic complications. Please, Eric.
Thank you very much, Clara. So, interscalene, maybe before starting, I just want to disclose that I received money from B. Brown, but that should not affect the content of this lecture. The interscalene brachial plexus block is considered by many as the gold standard pain treatment after shoulder surgery. It consists of injecting, so I'm just looking for my pointer. It consists of injecting the local anesthetics. I move here around. Anyway, okay. Between C5 and C6, within the interscalene groove between the middle and the anterior scalene muscle. On the top right, you have a cross-section of this region, and just below, you have the ultrasound translation. As I said, the interscalene block is considered as a gold standard pain treatment after shoulder surgery. However, it bears one of the highest rate of neurological complication. On the left part of the slide, you have an example of a 30-year-old male patient scheduled for shoulder arthroscopy. That was a rotator cuff repair. And actually, before the surgery, the physician performed an interscalene block and positioned the needle tip within one of the cervical root within the interscalene groove. And actually, he did not recognize where the needle tip was, and he injected 20 mils of local anesthetics. And the patient suffered from a severe and complete brachial plexopathy, and you can see here the expansion of the cervical root. This is a dramatic example, and here on the right you have another dramatic example. This is an example of a 55-year-old female patient scheduled for shoulder arthroplasty, and actually she was put under first, and after the induction the physician performed this interscalene block. Unfortunately, in that case, the needle tip was positioned within the spinal cord, and 30 mils of local anesthetics were injected, and the patient woke up fully quadriplegic. So with these two examples, we see that nerve puncture, direct trauma of the nerve puncture, intraneural injections do happen in regional anesthesia despite the use of ultrasound, and more often than what we think, Clara. Look at this article here. Dr. Liu and colleagues reviewed more than 300 supraclavicular and interscalene brachial plexus block, and they concluded that the rate of unintentional nerve puncture was between 16 and 17%. Again, 1 out of 6 patients in this daily practice sustained from an unintentional nerve puncture. And actually, this is not surprising, because maintaining the tip in constant view while advancing the needle is not an easy task. And in case of misalignment between the orientation of the probe and the needle, you might interpret this image as being the needle tip, while actually the needle tip is much, much further. And actually, this is one of the reasons why the rate of neurological complication has not decreased over the years, despite the use of ultrasound. And there is another example that I want to illustrate on these slides. Here, Dr. Orbo and colleague performed this very, very interesting cadaver study. They took 10 cadavers. They positioned the needle tip between 2 cervical roots, as you can see here, and then they injected an ink solution. After the injections, they dissected the cadavers and examined the cross sections under the microscope. Here is an example of an intact nerve. You can recognize the perineurium here with the fascicles, and you can see here that the ink solution has not crossed the epineurium. This is an example of an intact nerve. This is another example of a punctured nerve. Here, the ink solution has crossed the epineurium and now is between the fascicles. Again, the ink solution is between the fascicles. This is an example of a punctured nerve. And after examining all these sections, they concluded that 50% of their injections were indeed intraneural. And the explanation is because the resolution of the ultrasound machine is not accurate enough to let us know where the outer limit of the nerve is. Again, the resolution of the machine is not sufficiently good to tell us where the epineurium stops, and these issues lead some authors to question whether our vision is as sharp as we think it is, and whether we should not stay away from the nerve when providing peripheral nerve blocks. And actually, this is the path that we explored with my group with these 3 papers. We positioned the needle tip a few millimeters away from the brachial plexus. Here is a distance of 2 to 4 millimeters. And like that, theoretically, you reduce the risk of nerve puncture as you are away from the nerve. And you know that the block will be successful as long as the local anesthetic pushes the brachial plexus here towards the other direction. And when we compare this approach with a classic approach with an intraplexus injection, we found out that there were equivalent pain scores and morphine consumption at 24 postoperative hours. We also found out that the duration of analgesia was equivalent, and moreover, there was an additional advantage, which was a reduction of the rate of hemidiaphragmatic paresis from 90 to 20%. Indeed, the phrenic nerve lies between the sternocleidomastoid muscle and the anterior scalene muscle, and when you inject the local anesthetics here, it does not flow towards the phrenic nerve. So this is another advantage of this approach. So usually I inject 20 mils of BUPI 0.5% or ROPI 0.75% combined with IV dexamethasone. Thank you very much.
Thank you, Eric. So you can share with us your clinical pearls of how you managed to try and reduce the incidence of neurologic complications. How do you, in your clinical practice, implement these strategies? You look for moving away from the nerve, try to reduce the concentration of the local anesthetic.
Well, what I tell my residents is really to stay away from the nerve. I tell them to identify first C5 and C6, to approach the nerve with an in-plane approach through the middle scalene muscle from lateral to medial, and really to stay away from the nerve. I tell them that there's no need to surround the nerves with the local anesthetics, because if you want to surround the nerve, you have to multiply the number of needle passes. And the more needle passes you have, the more chance you get to puncture the nerve. So I really tell them, stay away from the nerve, 2 millimeters, 3 meters away from the nerve. 2 millimeters is a big distance on the screen, right? So stay away from the nerve, inject your local anesthetics, and again, as long as the local anesthetic pushes the brachial plexus toward the other direction, you're fine with that.
Do you have any data considering these maneuvers as if it actually can improve the clinical practice?
Well, the question is whether this approach can reduce the rate of neurological complications. Well, this is quite difficult to address, because actually the rate of neurological complications is very, very low. For the interscalene brachial plexus block, which has one of the highest rate of neurological complications, we are talking about a rate between 4 per 1,000 cases, 4 to 5 per 1,000 cases. So if you want to demonstrate that there will be a reduction of the nerve puncture, we will need a lot of patients, several thousands of patients. So again, theoretically, it should reduce the rate of nerve puncture because you are away from the nerve. In case you have this misalignment issue, you have a safety margin where you don't puncture the nerve.
So when you are performing the blocks, do you do it before the general anesthetic, for example? Do you make a combined technique, or you prefer just a regional anesthesia technique?
I would say it depends on the surgeon and it depends on the patients. But usually we combine this interscalene block with a general anesthesia, even if it's not necessary. Again, it depends on the surgeons and the patient, but we can really combine this block with a slight sedation, for example.
Do you, in your practice or in your hospital, do you have any post-operative follow-up for patients submitted to interscalene blocks?
Yes, all our patients are followed at 24 postoperative hour by the residents, the fellows, and other colleagues. And actually, we have also an acute pain service when we that follows the patients who have a perineural catheter, for example, and then they can adjust a different regimen. But I imagine that we're gonna talk about this topic later on.
Yeah.